Thanks, Dave. Thanks for letting me. Thanks for letting me jump in front of you there. I'm quite conscious of my time with you right behind me, though, so I'll get going. I have no disclosures for this case, so I'll be asking for some audience input on a couple of questions from it. This is a real case that was a lot of difficult decisions that had to be dealt with in the middle of the night. So it involves a 43-year-old female with a known hypertrophic cardiomyopathy. She presented to a community hospital in Nova Scotia with shortness of breath and increased leg swelling over the past few weeks. So other than her hypertrophic cardiomyopathy, which was diagnosed, she had a history of obesity and a previous atrial flutter ablation. And she'd recently stopped metoprolol as it had been bothering her stomach. So she had had a previous echo almost exactly a year prior in our institution, which showed moderate concentric hypertrophy. So I'm not going to show you the images because I have images coming up and in the interest of time, but she has a restrictive membranous VSD that measures 0.6 centimeters in its maximum diameter and had a gradient of 80 millimeters of mercury. She has a mitral valve systolic anterior motion with a resting left ventricular outflow tract gradient of 60 millimeters of mercury. She has moderate mitral regurgitation. So that was her previous echo. So I'll take you back to here in her presentation in a community hospital. So here's her electrocardiogram showing atrial fibrillation. Working diagnosis there, she was admitted to hospital, and the working diagnosis was that she had atrial fibrillation, she was tachycardic, and that led to a decompensation of her heart failure. So there they restarted her metoprolol. They started her on intravenous Lasix. They started with amiodarone with the hopes of her converting back to sinus rhythm, but this was discontinued secondary to hypotension. So at that point, after about 48 hours and not much headway with regards to her heart failure, a call came in and she was transferred to our center for ongoing management of her heart failure. So on arrival in our center, and it was actually in the middle of the night, there was a little bit of juggling as to whether she was sick enough to require transfer in the middle of the night, but she did come late in the evening. She was tachycardic at 130. Her blood pressure, systolic blood pressure, was 110 or 110 to 120 millimeters of mercury. Her JVP was distended. She had soft heart sounds, and it was noted that they had difficulty appreciating her systolic murmur. I'll just note that from a baseline creatinine of around 100, her creatinine was now 226, and she was sort of in and out of atrial fibrillation over the course of her stay. So I'm now going to ask what treatment people would suggest. So would they suggest A, IV Lasix? And I'll just ask for a show of hands. Who would suggest IV Lasix? B, IV fluids. C, IV metoprolol. D, dobutamine. E, which is Lasix and metoprolol. Or F, which is fluids and dobutamine. Okay, so a bit of a mix, but a lot. And then there's G, which is all of the above. Which maybe is what she got. Anyway, okay, so we'll keep going. So from this point, she quickly decompensated after arriving into our center into cardiogenic shock. And so I think just looking at her low pH, her lactate of 10, and the fact that she was in anuric gives you an idea of where she was at clinically. So they really had a tough time really stabilizing her and resuscitating her early. So they were unable to get any oxygen saturations non-invasively and struggled to get a blood pressure non-invasively. On top of that, they couldn't get arterial access and actually called cardiac surgery, who did a femoral artery cut down, and were still unable to get arterial access. So you can see this was quite a sick woman. So at this point, I think that their concern was that their working diagnosis with this was cardiogenic shock from worsening dynamic left ventricular outflow tract obstruction due to tachycardia and perhaps overdiuresis. So at this point, while this was going on, they were treating with intravenous fluids. They required phenylephrine and then eventually further vasoactive agents to try to maintain her blood pressure. So before, I'll just touch on briefly the treatment of acute hemodynamic compromise secondary to LVOT obstruction and hypertrophic cardiomyopathy. So these are usually precipitated by an acute event that will increase the LVOT obstruction. So contrary to how we usually treat heart failure, in this setting, you're looking at actually an opposite treatment. So these events are typically precipitated by things that either decrease preload or decrease afterload or increase the heart rate. Thus, treatment is based on increasing preload with fluids, correcting anemia, increasing afterload with phenylephrine, and trying to rate control, if you can, depending on your blood pressure, with beta blockers or disopyramide. Okay, so I'll move on to an echo, and truthfully, given her hemodynamic compromise, they struggled in the time of resuscitating her to get an echo done. So so I'll tell you, this is done in the middle of the night, and this is done in an obese woman. So the image quality is what it is. I'll just highlight a few things here, and so here we can see a parasternal long axis and sort of an off-axis view that's trying to highlight this membranous VSD that you have there. And here would be the gradient and I don't see it well, I think it was about 55 maybe millimeters of mercury. Just under 4 meters a second, so maybe more about 60 millimeters of mercury. So I'll move on now, kind of more of a 5-chamber-ish view, again highlighting, and I have to, sorry, I don't know if I can use my, I can use my pointer here. So highlighting this sort of aneurysmal membranous septum that's mobile with the flow through it there. And there was some question whether the flow looked increased when compared to previous images. And then here, just to show you that overall her left ventricular systolic function looks grossly normal. There doesn't appear to be a marked amount of systolic anterior motion of the mitral valve. And while they struggled to get a good gradient through the aortic valve there, so not much of a good-looking CW signal, but no clear elevation of the gradient through the aortic valve. So a new finding, and I just want to point out that when your 2D pictures are poor, often your color can be underestimated as well. So she had new, and I think even in the previous pictures you could see the tenting of the tricuspid valve. She had new severe tricuspid regurgitation, and because like I say, the color might be underappreciated there. I included a hepatic vein flow as well. Okay. So at this point, she's very sick. We have our transthoracic echo. What are people's thoughts on what the primary problem is? So I'll just ask for a show of hands again. So who thinks it's A, increase of left to right shunting through the VSD? A few takers. LVOT obstruction secondary to SAM. Did we miss the gradient on the? No, not many. Significant mitral regurgitation secondary to SAM? No. New severe TR? There's a few on that category. All of the above? Or there's something else going on? Okay, so some takers there. So we moved on, they moved on, and again, in suboptimal images in an ill woman with unstable hemodynamics. So on this image, I'm again focusing on this membranous septal aneurysm in here. But I think you can better appreciate on this TE the abnormal mitral valve. And as I move on here, you can see that in this scenario, really, she has severe mitral regurgitation secondary to primarily a very abnormal posterior leaflet and posterior leaflet prolapse. So she actually had this TE was not done at the time of her, but she had a subsequent TE later in her hospital stay that when she was more stable, that better shows this with 3D. So subsequently after that initial TEE, her treatment was switched to dobutamine to try to increase her output and try to work on decreasing her afterload. So she was treated as if she had severe mitral regurgitation. Over the next 24 to 48 hours, she improved dramatically, was able to be weaned off her inotropes, started making urine, and started making urine again. And I should say she was sick enough at the time that she was declined for, they couldn't get arterial access. ECMO was considered. She was declined for VED, so she was very sick. So that was quite an improvement. And I think I did show this image earlier, but again, from her transthoracic study where the clues were here, you're looking at an eccentric jet of mitral regurgitation, which we know can be underestimated. And I think while the mechanism of mitral regurgitation in hypertrophic cardiomyopathy is often systolic anterior motion of the mitral valve, that would generally lead to a more posteriorly directed jet rather than the anteriorly directed jet seen here from this posterior leaflet prolapse. So I think from when we look at some of the important cases, the echo assessment of hypertrophic cardiomyopathy is probably one of the most inclusive ones we have. And the causes of heart failure are numerous, and including diastolic dysfunction, problems due to LVOT obstruction, mitral regurgitation from various mechanisms, and in people who are more end stage, left ventricular systolic dysfunction. In addition, I think it's important to consider the various abnormalities that can be seen in hypertrophic cardiomyopathy. So while they intrinsically have abnormal valves with hypertrophied and anteriorly displaced papillary muscles that can help lead to, and they can have abnormal leaflets that are with increased leaflet area and they're elongated. There's also associations with mitral valve prolapse seen. So the mechanisms for the mitral regurgitation can be complicated in hypertrophic cardiomyopathy. So to finalize, patients, I think my big learning points from this case would be patients with hypertrophic cardiomyopathy have multiple mechanisms of heart failure. They can often have abnormal mitral valves with various pathology involved. And it's important to note how mitral regurgitation can be underestimated with transthoracic echo. And if you have any hint that the mitral regurgitation might be worse, then particularly with an eccentric jet, you should be looking at transesophageal echo.